Now I welcome to our talk today by Dr. Teodor Stefanov, and he is talking about the perioperative anemia and the patient blood management, perioperative risk modifications, and operative. Can we improve the outcome of patient of anemia, for example? We will see. Dr. Teodor, he has graduated from the Medical University of Sofia in Bulgaria, and this is the university in Bulgaria. And after that, he was trained in Bulgaria and UK. After his training in UK, he traveled to China, where he worked as consultant cardiac anesthesia and ICU for 2 years. And all this photo from the Changchun, China. I don't know I told it correct or no, but I hope so. After his work in China, he came in 2016 to Abu Dhabi to Cleveland Clinic, where he is working now as a medical director of the pre-anesthesia testing clinic, in addition to his clinical anesthesia service, of course. And at the same time, he is assistant professor of anesthesiology in Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio, United States. And again, the talk of the Teodor about the perioperative anemia and the patient blood management. So welcome, Dr. Teodor. I hope you will enjoy his lecture, inshallah.
Thank you, Dr. Yasser, for the kind invitation. You've done a great research about my previous employment. It was really, really nice. Thank you, Dr. Saad, for the invitation. I will try to fit into the time frame. I think it will take a bit more. So these are my disclaimers. I have no financial disclaimers. I am the Cleveland Clinic Abu Dhabi principal investigator for the ITAX trial, which I will mention later. And above all, I'm a practical jobbing anesthesiologist and perioperative medicine enthusiast and a student, as a matter of fact. The objectives of this talk will be to outline the patient blood management, describe some of its elements, describe the significance of perioperative anemia for patient outcomes, define anemia as a modifiable perioperative risk factor, and I'll present some of our experience in Cleveland Clinic Abu Dhabi for preoperative anemia optimization as our quality improvement project. What I will not be talking about is basically how bad is blood transfusion, how to avoid it, alternatives, and restrictive transfusion triggers. To take blood transfusion a bit seriously, we need to think of it as an organ transplantation. We take solid organ transplantation pretty seriously, but I don't think we have the same attitude towards blood transfusion. A bit about the history of blood transfusion. In the beginning, the question was, can we do it? The compatibility, safety issues, the improvements in the storage. Then came, can we do this on a larger scale? That's the era of the modern blood banking. Soon after that, we realized, should we be doing it that often? We discovered some potentials of poor outcomes associated with transfusion. And even the question was, can we live without it? And this is the Jehovah's Witnesses' accomplishment. Pleiad of terms were emerging at that time, in the modern time, in the last, let's say, 20, 30 years. We started talking about transfusion medicine, blood banking, transfusion-free surgery, alternatives to transfusion, blood conservation. It was the product at the focus of most of this. And what we needed to do is shift that focus from the product to the patient. And that's how patient blood management came into view. It was a term forged by Professor James Isbister in 1998. He is an Australian hematologist, and I read the definition. Patient blood management is a primary application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. It got widespread after World Health Organization endorsement in 2005. Pleiad of organizations are out there promoting and developing and supporting patient blood management. It is also endorsed by the Joint Commission International, and there is a special patient blood management certification awarded by them. Patient blood management is defined as 3 pillars of patient blood management, divided into the three periods of surgery: preoperative, intraoperative, and postoperative. There are so many domains and elements of patient blood management that not 1 hour, maybe 10 hours are needed to describe all the evidence, all the support, all the logic behind it. The 3 pillars support patient blood management. I don't particularly like that concept of pillars, because if we knock out the middle pillar, supposedly patient blood management will still be supported. I would rather think of patient blood management as a jigsaw puzzle, when you don't see the final perfect picture until the last piece of the jigsaw puzzle is in its place. The modern view of patient blood management is the matrix of patient blood management, all centered and intertwined into improving patient outcomes. And what I will focus a bit more this evening only is the domain of managing anemia. Successful blood management, patient blood management program lies on a foundation of knowledge about transfusion, outcomes, alternatives, and costs, of course. It needs a lot of commitment from all the team involved in treating the patient. It needs, of course, leadership, and it needs a lot of support from the hospital, from the authorities, and from the societies. We like to see patient blood management as a unique opportunity in modern medicine. For most of the modern treatment, in order to improve the value of given treatment, we need a solid investment, a solid cost. Every new medicine comes at a great cost, and we hope that it will improve the outcomes and it will improve the quality. Patient blood management potentially delivers a higher quality, better outcomes at lower expenses. By lowering, for example, the blood transfusion rate, we improve the outcomes, hence the value is increased in much greater aspect. Does patient blood management actually work? As 2020 came with surprises, so 2021 did, supposedly. Preparing for this talk, I looked at some brand new evidence, fresh from the oven. So this is just a fresh publication from British Journal of Anesthesia, which comes with the bright headline that patient blood management interventions do not lead to important clinical benefits or cost effectiveness for major surgery. And this is supposedly a network meta-analysis, which is quite statistically difficult to make my head around it and comprehend it. What it actually presents, it is a meta-analysis of 312 trials of more than 50,000 participants, focusing on only some elements of patient blood management, namely 8 trials looking into iron therapy, some trials looking into salvage, a lot of trials looking into use of tranexamic acid, few trials looking at point of care coagulation testing. That actually, what they discovered is that there was significant reduction in exposure to red cell transfusion in participants allocated to patient blood management interventions. However, these 5 elements, the use of these 5 elements separately or in conjunction, did not lead in this meta-analysis to reduction in mortality or 30-day mortality, acute kidney injury, brain injury, myocardial infarction, sepsis, or low cardiac output. It did decrease hospital length of stay, and of course, did decrease transfusion rate. So actually, these interventions work according to my read. Maybe patient blood management works with a bit as enhanced recovery programs. So you have to implement all the elements at an organization, at a care level. So this is a big study from Australia where patient blood management is introduced since quite a few years at a national, almost national level. In 2008 in Western Australia, they implemented a comprehensive health system-wide patient blood management program. 2008 was the year of their highest use of red blood cells. So at that year, they used 70,000 units they had been transfused. In the next years, the graph depicts gradual decrease of the blood products issued At the same time, there was increase of the population that this healthcare system catered to. They looked at mortality, which was decreased. They looked at hospital length of stay, which was decreased. Hospital-acquired infections were decreased, and acute myocardial infarction was decreased. Of course, possibly this is not only consequences of patient blood management program implementation. Healthcare is getting better and better as we speak, but these elements translated definitely help to support this improvement in outcome. Very importantly, there was a very significant cost reduction. Blood product administration decreased from the year of implementation to the final year for 41%, and this translated into close to $100 million estimated activity-based savings. Anemic elective surgery admissions decreased from 20 to 14%. This is another example of patient blood management implemented at a healthcare system-wise. It is a German work. They looked at their pre-patient blood management and post-patient blood management program, EPOC. So what did they find is that blood loss decreased, hemoglobin levels before transfusion were lower because they were lower transfusion thresholds, that all blood products transfusion rates decreased significantly, use of units per patient decreased significantly, and despite that, discharge hemoglobin was higher in the patient blood management EPOC era. The rate of kidney injury was decreased, hospital length of stay was decreased, and there was a small but significant decrease in costs. What would represent a successful patient blood management? Would it be the reduction of transfusion rate, improved hemoglobin perioperatively, better patient outcomes, reduction of cost, or all of these combined? I believe it is a combination of these factors. And if we look at blood transfusion as a risk factor for poor patient outcomes, are there modifiable and non-modifiable risk factors for blood transfusion? Of course, some things we cannot change, like, for example, the size of the patient, the major surgery that they are coming to have. But are there actually some risk factors for transfusion that we can interfere and modulate? The British came with this score predictive of blood transfusion for cardiac surgery. It's Professor Klein in Perop Hospital in Cambridge. There are several risk factors coming into the calculation. It is the age of the patient, the gender, the preoperative hemoglobin, the body surface area, the UV score, the creatinine, and the type of operation the patient is having. And all of these bear some weight and give a point, certain points. And if you have about 15 points, the risk of transfusion is about 50%. If you look again at what carries the highest points, it is hemoglobin less than 110, it brings 9 points. So if you have a mildly anemic female patient coming for a double valve procedure, this will define risk of transfusion definitely more than 50%. And all of these, probably the only modifiable risk factor is the preoperative hemoglobin level. So when I started working in Cleveland Clinic Abu Dhabi, I was surprised, even it was very interesting to find out that there is a huge percentage of patients who present anemic. I didn't know, is this population factor or is something else? So we wanted to have a deeper look into it. So we started our preoperative anemia optimization initiative. We wanted to audit the incidence of anemia in our institution, to examine the awareness and vigilance of our staff towards preoperative anemia. We wanted to figure out what are we doing at this present moment about preoperative anemia and find out can we do better and collaborate with other specialties. It is a well-known fact that the knowledge of the medical community about patient blood management is not great. So this is a nice publication that came in 2017 from possibly thought leaders in the fields who threw out a survey in their institutions about patient blood management, about 30 questions to estimate the level of knowledge and understanding of the problems related to preoperative anemia, transfusion, and patient blood management in general. Lots of data coming out of this. The general conclusion of this is that the knowledge is limited, and these are Western European leading thought centers. For example, the percentage of clinicians who routinely treat preoperative anemia in different hospitals varies from 10 to 50% around different nations, like Sweden doing worst, the Netherlands not great, Denmark also not great. And when asked what would be the therapy of choice for treating preoperative anemia, interestingly, 38% of the respondents chose blood transfusion as such. So in order to get to know what is our reality, we conducted a survey monkey, initially thrown out into our anesthesia department and then to broader Abu Dhabi Anesthesia Society through Abu Dhabi Anesthesia Club, kindly directed by Dr. Yasser. So there were 10 simple questions and we got about 60 respondents. I wanted to test what is the perception about hemoglobin, what we define as anemia. So half of the people would think that this level of hemoglobin for that woman would be normal. And also that level of hemoglobin for that gentleman would be normal. Quite a few people thought that this is perfectly fine. Probably the problem is how do we define anemia? And the widely accepted definition is the World Health Organization definition, which defines anemia for male less than 130 and for female less than 120, and with severe anemia being less than 80. The rest of the questions in the survey I based on this very nice overview of the problems related to patient blood management, fit to fly, overcoming barriers to preoperative hemoglobin optimization in surgical patients by the Spanish hematologist Manuel Munoz. The first question was, how do we think, is the incidence of anemia in surgical patients the same or different from the general population? And half of us thought that it is the same. And this is a common misconception according to Professor Munoz's review, because in surgical patients in Western world, actually prevalence of anemia is much higher than in the general public. However, this varies across populations. In Europe, about 10% of the population is anemic, and in Southeast Asia, 57% of population is anemic. So having every second patient anemic is the norm, but definitely is not normal. Where is Abu Dhabi and United Arab Emirates falls into the category of North Africa, Middle East, and according to this graph, about 40% of the population is supposed to be anemic. Excuse me, the position is not very good. In different surgical populations, there was found, this is a meta-analysis, pooled data from many studies, in some groups of patients like gynecologic surgery, vascular surgery, the incidence of anemia could be up to 50%. But I didn't need to do the survey. It was in the news. This is a publication with regards to World Health Organization forum that was conducted in Dubai a few years back, and 40% of UAE population is actually anemic. What was the incidence in our hospital? We looked at all data of the patient who were having some kind of procedure, with or without anesthesia, interventional procedure in 2017. And in surgical patients, the incidence of anemia was 30%, but in cardiac surgical patients, it was 44%. And overall, in our patients, it was 40%. So in our case, specifically, the incidence of anemia in our patient population is similar as the same general population. Is anemia for a surgical patient a problem? This is one of the big questions that I will try to answer tonight. Most of the respondents thought that mild preoperative anemia in a surgical patient should not be treated and should not be delayed. Surgery should not be delayed because of its presence. It is simply not a problem if the patient is slightly anemic. If we look at the pillars of patient load management, it clearly says that unmanaged anemia is a contraindication for elective surgery. It's rather a bold statement, but it could be true. In this large meta-analysis, probably one of the best depicting evidence suggesting association with preoperative anemia and outcomes, they analyzed data from more than 200,000 patients from the NSQIP National Surgical Quality Improvement Program database in the United States. It is a rather busy slide, but I'll try to guide you through it. So these are different risk factors that patients could have. And on this slide, we see 30-day composite morbidity. If the patient does not have the risk factor, say that these are the small bars, so the patient has no cardiac disease, they still have some kind of morbidity. Like for most of the patients, it runs about the 4% mark, a chance of running into some kind of a problem. The middle bars show the morbidity, the rate of complication in patients with the given risk factor. Say patients with cardiac disease, they have 13% chances of running into some kind of a complication. If they have cardiac disease and anemia, they are in 21% chances of having a perioperative complication in 30 days. And the blue bars stand out high for every given risk factor, and this was significant for all of them. The same picture for mortality. And if you have renal disease, for example, and you are anemic, you have 13% mortality, 30-day mortality. And for sepsis, it is 15% mortality if you have sepsis and you present anemic for your surgery. One of my favorites in this topic is the Italian by Professor Marco Lanucci from Milan, major bleeding, transfusion, and anemia, the deadly triad of cardiac surgery. This was a single center prospective data, about 16,000 patients over 12 years. We just look at the last column. So the black bars represent presence of preoperative anemia. So if the patient had a major bleeding and was transfused and had preoperative anemia, we had 24% operative mortality rate. In a recent snapshot trial, multi-central, 1-week snapshot study of incidence of preoperative anemia and association with complications, showed that on the left-hand side, the mortality starts picking up maybe somewhere about the 10% mark, and the confidence interval starts widening up. And on the right-hand side, we see the complications rates. It starts picking up somewhere at about the 12 mark. This is a Brazilian study about cancer surgery, elective abdominal surgery, finding out what are the risk factors of postoperative complications. And they found out that preoperative hemoglobin below 12 doubles the risk of complications. Probably one of the largest meta-analyses in anesthesia, including close to 1 million patients, association of anemia and mortality after surgery. Forest plot is much on the right side. The odds ratio for mortality is 2.9. The same association for acute kidney injury and some association for infection. How about long-term effects? One would think that the patient goes through surgery, they have a problem or not, and they are fine after that. This is an American study in orthopedic surgery. So they followed up their patients up to 3 years after their operation, and they found out significantly higher mortality, standing there even for mild and moderate anemia. Up to 20% of the patients who were moderately anemic at the time when they presented for their surgery were not alive 3 years later. And this is a German study. They followed up their cardiac surgical patients long time after their operation. In 3 years, they found that 15% of the non-anemic patients, 30% of the mildly anemic patients, and 51% of the severely anemic patients were not alive. Is it difficult to investigate and treat preoperative anemia? What does it take to make a diagnosis? And most of us thought that it is actually not difficult. A third of us thought that it takes a lot of hospital resources and it is not cost effective. And this is one of the misconceptions debunked in Professor Munoz's nice review. There is a recent consensus statement on perioperative management of anemia and iron deficiency published in Anesthesia 3 years ago. And it outlines easy to follow algorithm of managing and diagnosing preoperative anemia. Interesting fact is that they removed the gender segregation that any patient with hemoglobin of 130 and below is considered to be anemic and should be investigated for the etiology of their anemia. Basically, it focuses on ferritin transferrin saturation and uses C-reactive protein to differentiate between pure iron deficiency or functional iron deficiency and chronic inflammation, anemia, and uses the vitamin B12 and folate levels to differentiate megaloblastic anemias and other anemias. In our population in UAE, we would think that at least half of our anemic patients would be iron deficient. These are the green bars in these graphs. So we designed our small algorithm, how to diagnose it. We made it even more simple in Cleveland Clinic. We looked at the red cell volumes initially, and if they were low, we did order ferritin and iron saturation. And recently, we started using reticulocyte hemoglobin equivalent, and I will come back to this a bit later. So why not? What kind of iron should we use if we are to treat the iron deficiency anemia, oral or intravenous? It's a bit more complicated when oral iron would work and when it would not. But the question was, would high dose oral iron would be effective treatment for preoperative anemia with functional and absolute iron deficiency? A bit complicated. Basically, if you have inflammatory or chronic disease state, oral iron is not being absorbed. So it doesn't really work, but it may work if you have absolute iron deficiency, usually related to blood loss. And this is another misconception that oral iron is for everyone. And there is a historic misconception about the use of intravenous iron perceived like highly anaphylactogenic and dangerous, potentially expensive, associated with a lot of side effects. And indeed, most of us thought that this is the case. As a matter of fact, it's not. Modern intravenous iron preparations are quite safe, and complication rates is very, very low, with nausea being the most frequent complication. Anaphylactoid reactions are below the 0.5% mark. And their alternative potentially is transfusion. Transfusion has a much higher complication rate in some aspects. And we use in our hospital ferric carboxymaltose as a first choice treatment. So the big question, is there enough evidence that treating preoperative anemia would improve outcomes? We were hoping to have a definite answer of this question, at least for major abdominal surgery, and we are all very certain that the PREVENT trial will answer this question. It was published in September and caused a lot of turbulence in the patient blood management world and the intravenous iron enthusiast. So it is a very well designed, prospective, blind, randomized, double-blind randomized trial conducted in the UK in about 1,000 patients scheduled for major open abdominal surgery. They were given 1 gram of ferric carboxymaltose, and there was no difference whatsoever between the outcomes of the two groups, as the primary outcome of this trial was death or blood transfusion. And we all thought that giving intravenous iron would treat anemia, definitely decrease the transfusion rate, but this was not confirmed by this trial. It was a pragmatic trial. It was conducted to follow normal practices. So most of the patients have been seen about 15 days before their surgery, with interquartile range between 12 and 22 days before their surgery, and they have had their drug, their research treatment about that time. Interestingly, they were not quite anemic at the time of randomization. So the mean hemoglobin was about 11 in both of the groups. And there were very few patients who were quite severely anemic. As a matter of fact, more than 80% of the patients in both groups had a hemoglobin above 100. Probably there is some selection bias. Probably patients who had bad anemia were considered not to be ethical, not to be investigated and treatment. This is something that I cannot answer. Is it the case or not? But this is the most interesting in the PREVENT trial, that actually anemia was corrected in only 21% of the patients in the intravenous iron group. And as a matter of fact, 10% of the patients in the placebo group also had their anemia corrected by the day of their operation. So in this way, the trial title, Preoperative Intravenous Iron to Treat Anemia Before Surgery, is a bit of a misnomer, because actually anemia in the research trial was not treated preoperatively. As a matter of fact, the patients who received IV iron had an almost normalization of their hemoglobin levels at 8 weeks, which was sustained at 6 months after the operation. So this therapy was effective in treating post-operative anemia. And an interesting association came out of the trial. The patients who received intravenous iron were less likely to be readmitted to hospital within 8 weeks of their operation, potentially giving a signal of less hospital, less complications on the long term after their discharge. We have to ask ourselves, are we asking the right questions when we conduct research in patient blood management and anemia? Are we looking at the right outcomes? Should we be using the traditional outcomes? How much blood did the patient get? How much blood did the patient lose? How many are dead or alive? Or focus more on patient-centered outcomes? How did the patient do? How does the patient feel after the surgery? And hopefully we will have a better answer again to the question, would preoperative anemia treatment by intravenous iron be effective in improving patient outcomes when the results of the ITAX trial come? So intravenous ITAX trial is trial of intravenous iron for anemia before cardiac surgery. Cleveland Clinic Abu Dhabi is participating in this trial. We managed to recruit few patients, 29 sites. This is multi-centric international double-blind randomized trial. We aim to treat 1,000 patients, with the primary outcome of this trial is days alive and out of hospital. And actually now it's being changed as we speak, days alive at home at 30 days after the operation, which is a composite of death, hospital stay, need of rehabilitation, readmissions, and basically quality of life, because we believe if the patient is at home, they have a good quality of life. So we will have a bit more of a patient-centered outcome answer to the question, is intravenous iron effective in treating preoperative anemia? And how about post-operative anemia? Is this a problem? Because we know if the patient comes anemic, they lose blood, we transfuse them, they are still anemic in the first days after the operation. Sometimes they get even more anemic if they spend some time in intensive care. Another interesting article, fresh from the internet oven of British Journal of Anesthesia, published online ahead of publication, association between postoperative hemoglobin and the so fancy MINS, myocardial injury after non-cardiac surgery, coming from Daniel Sessler's group in Mothership, Cleveland, Ohio, in collaboration with other researchers. For me, this is a very interesting observation. This was data for patients who are also participating in other major trials like the POISE and the Enigma and the Vision trial, patients that had data for postoperative troponins, of course, bigger surgeries. Interesting fact that overall there was about 3.5% incidence of MINS, but there was none increase in troponin levels in patients who had normal postoperative hemoglobin levels. And every gram decrease in hemoglobin level led to 30% increase of chance of getting a myocardial injury after non-cardiac surgery. And there is again a lot of associated data that troponinitis after non-cardiac surgery can be predictive of worse postoperative outcomes and even mortality and long-term cardiac problems. Another interesting trial, which is not so strong, but it's still interesting to consider, is postoperative anemia as a risk factor for postoperative delirium. And anemia would increase fourfold the risk of postoperative delirium. And we know that postoperative delirium is associated with bad outcomes and mortality. Interesting question to ask ourselves, is it actually anemia the problem or the iron deficiency? The heart failure world, the cardiologist world, has been going strong after treating iron deficiency in heart failure patients. Probably started about this time, 2009, when this publication came about intravenous iron in heart failure. Patients were given in a randomized manner a small dose, only 200 milligrams of ferric carboxymaltose if they were iron deficient. And self-reported patient global assessment, which is a survey of health-related quality of life, it improved significantly with the treatment. The patient's 6-minute walk test improved at 4 weeks and 12 weeks, and this was sustained at 24 weeks after the surgery. And patient's functional class, New York Heart Association functional class, decreased significantly with 1 level at even 4 weeks after the intravenous iron. So these patients did well, did better after having intravenous iron, having heart failure based on data from surgical world. Iron deficiency is associated with higher mortality in patients undergoing cardiac surgery. This is a Swiss study. And if the patient has no anemia, but they are iron deficient, which is a relatively common scenario here, they have an increase from baseline 90-day mortality of 1% towards 4%. And if they are anemic and iron deficient, the dramatic increase from 4 to 12%. And the same for other adverse events. So iron deficiency, with or without anemia, is associated with worse outcomes.
Okay.
So back to our hospital, what did we do there? Our optimization initiative started 2017, investigating how we are doing, what is the incidence.
Now, Dr. Teodor, please consider the time, okay?
Okay, I think I have only maybe 2 minutes. I will skip that fast forward. This is our preoperative anemia investigation protocol. As I mentioned, we use ferritin, TIBC, erythropoietic hemoglobin. We use a collaboration with primary care. So if they are definitely iron deficient and have no kidney problems or other major problems, we refer them to primary care, who is responsible of investigating the reason of their iron deficiency if they deem needed, say an elderly gentleman who didn't have a screening colonoscopy, they may consider the need of it, and they do treat their iron deficiency anemia with ferric carboxymaltose. We coordinate this through our preoperative assessment clinic, and we decide when to proceed with surgery. Depends on the patient considerations, patient factors, the surgical factors. We communicate with the surgeons the urgency of the procedure and the time frame that we can allow to treat their patient, their anemia. So we compared our data from 2017 before starting our preoperative anemia optimization initiative to 2018. And the documentation of anemia in our files was much improved with our educational initiatives. We believe that we started paying more attention to anemia. As such, we did investigate anemia better. We did order tests more if the patients were anemic. We did prescribe more iron medications if the patient was iron deficient. And in 2018, we treated 115 patients referred to the pathway, which is about 6 months of work. 60 patients have received IV iron. And there was, of course, significant hemoglobin in a huge percentage, significant increase in their hemoglobin levels in huge percentage of the patients that we treated. It mostly depended on the time frame between the treatment and the surgery. And with some patients, there was a dramatic increase of doubling of their baseline hemoglobin with intravenous iron. Maybe a matter of chance, we didn't really do a significant statistical analysis, but in 2017 we had 30% of anemic elective surgical admissions, and in 2018, 27%, small reduction of 3%, but 10% relative risk reduction, and we hope this is some kind of result of our work. So far, we have had about more than 600 patients going through our preoperative optimization pathway. So what I would conclude, anemia remains underappreciated, potentially modifiable perioperative risk factor. We may need to focus a bit more on postoperative anemia, as this may be clinically significant. Intravenous iron alone is unlikely to be beneficial for all anemic patients. Probably it will be beneficial for patients who are iron deficient. Iron deficiency per se emerges an independent modifiable risk factor, and probably we need more research focused on patient-centered outcomes. Maybe this is the right way forward. Despite the few clouds in the sky thrusted by event trial and other research work, I believe there is a sunny day coming over patient blood management in Cleveland Clinic Abu Dhabi and worldwide. Thank you very much.
Thank you very much, Teodor. And I don't have a lot of questions, just two questions. The first, the same is principles you mentioned. It is for children or pediatric patients as well?
The principles definitely are the same. Patient blood management is something that can be tailored towards the specific population you're catering to and the specific surgeries that are being done. So it is not one size fits all. Definitely patient-centered approach is beneficial. You should consider what is best for this patient having that surgery, not having a blanket approach.
Actually, some conclusion from myself from your lectures. Generally, anemia is more dangerous than blood transfusion because the side effect of blood transfusion is much less than the frequency of the complication you mentioned. Postoperative delirium, myocardial ischemia, myocardial infarctions, and other complications you may not mention it. The other issue also, the importance of preoperative management. I think we should include the nutritional support as well, because some anemia may be to the nutritional deficiency or malnutrition. What do you think?
Yes, absolutely. This is a very good point. We see, of course, anemia, and this is very frequent in frail patients. patients come in to have a cancer surgery after chemotherapy. And we know that malnutrition and anemia go hand in hand. So we cannot improve anemia if you don't improve overall nutrition status.
Correct. Yeah. The last point from myself, we should differentiate in anemia between in cardiac surgery patient, non-cardiac surgery, and the limits coming from the critical care. I can't apply the conservative blood management in ICU in my patient under anesthesia or coming for general for cardiac surgery. So my opinion, there is no conservative blood management during acute resuscitation of the patient in OR, either acute bleeding from surgery or trauma or something like that. Maybe hemoglobin 9, 10 will be is okay. Intraoperative.
This is absolutely correct. And actually it is in the latest European Society of Anesthesiology and Cardiac Surgery Patient Management Guideline. They don't fix numbers as transfusion thresholds. They advocate individualized thresholds based on evidence of end organ ischemia.
Because of the time, thank you very much, Teodor, and we are going to Dr. Hoda and Dr. Haitham now.